Welcome. If you're listening to this, you aren't just a casual learner. You're a senior clinician, an airway operator, or a consultant in emergency medicine.
Yeah, you know what it's like in the thick of it.
Exactly. And today, we're taking a completely different approach to our usual deep dive. We're actually putting you directly into the center of a mental simulation.
Right, an active cognitive walkthrough.
Yeah. Our focus is the Comprehensive Expert Guide to Emergency Airway Management. We're synthesizing the ID-SOP-ME UP2 mental model, the latest 2025 difficult airway society paradigms, and of course, the pharmacological data from the Lions trials.
Well, the landscape of emergency airway management has fundamentally shifted for those of us operating at the senior level. I mean, it's no longer just a technical procedure, just sliding a plastic tube between vocal cords.
Right.
It is a highly sophisticated, really high-stakes cognitive and physiological intervention. So we're going to guide you through this simulation using the PEDAL AP framework. That's physical, environment, task, timing, learning, emotion, and perspective.
And our ultimate benchmark today isn't just getting the tube. We're aiming for DAH1A.
Yes, a definitive airway sans hypoxia, hypotension, or hypercarbia on the first attempt.
Let's drop right into part one, the trigger. I want you to mentally transport yourself into this scenario to really engage those physical, environmental, and emotional domains.
Put yourself right in the room.
You are the airway lead. It's 03.00 on a Saturday morning. You're standing in the resuscitation bay of a massive, busy tertiary UK A&E. Feel the environment.
It's intense.
The stark fluorescent lights are buzzing overhead. You can feel the slight restriction of your PPE gown across your shoulders. The air smells faintly of sterile prep, mingling with the metallic tang of blood from the trauma bay next door.
Yeah, that smell never really leaves you.
But your focus is entirely on the relentless, high-pitched alarm of the monitor. Beep, beep, beep. The tension in the room is heavy. You have an FY2, a registrar, and a couple of resus nurses looking directly at you for the plan.
And here's the clinical picture you're faced with. This is a critically ill patient in type 1 respiratory failure. They're profoundly hypotensive, and their blood gases reveal a severe metabolic acidosis secondary to sepsis-induced DKA.
A true halo event.
Exactly. High acuity, low occurrence. As the airway operator, your primary threat right now is not anatomical.
Yeah.
I mean, the airway might look like a grade 1 view from the end of the bed, but the physiology is a ticking time bomb.
Let's break down that physiological threat, because I think a lot of airway checklists still lean really heavily on anatomical predictors. Like, I've always used the lemon mnemonic for a quick airway assessment.
Sure, lemon is standard.
Yeah, so why are you advocating we throw that out in this specific scenario?
Well, lemon, looking at the jaw, evaluating the 3-3-2 rule, assessing the Mallampati score, that's brilliant for a stable elective case in the anesthetic room.
Right.
But in the resus bay, it completely misses the physiological context. For this patient, we need to apply the Heaven criteria.
Hypoxemia, extremes of size, anatomic challenges, vomit or fluids, exsanguination, and neck mobility.
Exactly. It forces you to look at the systemic state of the patient, not just their mandible. Or rather, it contextualizes the anatomy within the physiology. Right now, your patient has severe hypoxemia and exsanguination, which, in this medical context, translates to profound distributor shock.
Just those two Heaven criteria signal an unacceptably high risk of first-pass failure, right?
Oh, absolutely. And peri-intubation arrest. This introduces the concept of the HOP killers: hypotension, oxygenation failure, and pH, meaning acidosis. This patient has all three.
The acidosis piece is terrifying here. I mean, sepsis-induced DKA means this patient is relying on a massive compensatory respiratory drive, that deep Kussmaul breathing, just to keep their pH compatible with life.
And that is the crux of the CRH mnemonic: consumption, right heart failure, acidosis, saturation, and hypotension. Think about the hemodynamics of what happens if we push a paralytic right now.
They stop breathing.
Right. If you subject this patient to even 60 seconds of apnea without meticulous preparation, you completely remove that compensatory minute ventilation. Their carbon dioxide will skyrocket, their pH will plummet off a cliff, and the resulting intracellular acidosis will severely depress the myocardium.
You'll precipitate an immediate cardiovascular collapse.
Exactly.
Which brings us to the actual execution in part two, the walkthrough. We're incorporating the task, timing, and learning domains here. You're at the head of the bed. Adrenaline is spiking. The patient looks dreadful. The FY2 is nervous. And the natural urge in the room is to just push the induction drugs immediately and secure the tube before the patient codes.
It's a really strong urge.
How do you override that?
You have to master the timing domain. You must embrace the discipline to resuscitate before you intubate. You actively choose to pause. We initiate a delayed sequence intubation, or DSI,
Okay, walk us through that.
by administering a carefully titrated dissociative dose of ketamine. We keep the patient spontaneously breathing and maintaining their own airway reflexes. But we calm their delirium and reduce their oxygen consumption.
Buying time.
Yes. This buys the team a critical 3 to 5 minute window to physiologically optimize them before we ever consider paralysis.
So you've bought that window. Now you verbalize the IE-SOAP UP2 checklist to the room. Let's walk through the mechanics of that. IE is for IV access. According to the DE guidelines, we shouldn't be fishing for veins blindly in a shut-down, shocked patient.
Definitely not. Peripheral vasoconstriction in shock makes blind attempts a complete waste of precious time. You direct your registrar to grab the ultrasound for an early ultrasound-guided peripheral IV.
While they secure access, we move to D, define the difficulty, and decompress.
This is where you establish the shared mental model. You look at your team and state plainly this is a physiologically difficult airway due to severe acidosis and shock.
I want to pause on the decompress part of D. We're asking for an OG tube here. For a senior clinician, what is the deep physiological reasoning behind prioritizing stomach decompression in this specific moment?
It comes down to splanchnic perfusion. In severe shock and sepsis, the body shunts blood away from the gut to protect the brain and heart.
Makes sense.
Right, so that ischemic gut stops moving. You get an ileus. This patient's stomach is likely distended with fluid. If you paralyze them, that fluid is coming straight up the esophagus. Emptying the stomach proactively is your best defense against catastrophic aspiration during your apneic window.
Okay, moving to S&O, suction and oxygen. For suction, you set up the SALAD strategy, suction-assisted laryngoscopy and airway decontamination.
Crucial step.
You take your wide-bore Yankauer, test the negative pressure, and physically park it under the patient's right shoulder so you aren't looking for it when things go wrong.
Yeah, you need it immediately at hand.
And for oxygenation, the guidelines recommend the triple 15 rule. But let's clarify the logistics of that, because you can't just throw 3 masks on a patient's face.
Right, the application really matters.
Yeah.
Triple 15 means 15 liters per minute via nasal cannula, 15 liters via non-rebreather, and 15 centimeters of water CPAP if their saturations are still lagging.
Physically, how does that work?
You place the nasal cannula on the patient first, and then the CPAP mask goes entirely over the top of the cannula. The crucial detail is that when you remove the CPAP mask to intubate, that nasal cannula stays running at 15 liters per minute.
To provide apneic oxygenation.
Exactly. Pushing oxygen down the pressure gradient into the lungs while they're paralyzed.
Now for A and P airway equipment and positioning. Positioning is arguably where the battle is won or lost before you even pick up the blade. We're aiming for flex tension. We aren't just talking about pushing a button to raise the bed.
No, we're talking about the advanced biomechanical advantage of aligning the atlanto-occipital joint.
Break that down.
The physics of flex tension, or the bed-up head elevated position, are vital. By flexing the lower cervical spine and extending the atlanto-occipital joint, you're aggressively flattening the primary oropharyngeal curve and the secondary pharyngoglottic curve.
So you're creating a straight line.
You want the external auditory meatus perfectly aligned horizontally with a sternal notch and the face parallel to the ceiling. You are engineering a straight line of sight for your device.
Perfect. Let's get into the pharmacology, the M for medication. This is a massive decision point. The choices made here will dictate the patient's hemodynamics for the next 20 minutes.
We lean heavily on the data from the Lions trials here. If this were a neurocritical patient, say the massive traumatic brain injury, you might use the 3.2.1 regimen to heavily blunt their sympathetic response and prevent a deadly spike in intracranial pressure.
But our patient is in profound distributive shock.
Exactly. Their sympathetic nervous system is the only thing keeping their mean arterial pressure viable. If you hit them with a 3.2.1 dose, you will ablate that endogenous catecholamine drive, and their blood pressure will drop to 0.
So we pivot to the attenuated regimen to protect the hemodynamics.
Correct. We select the 1.1.1 regimen, 1 microgram per kilo of fentanyl, 1 milligram per kilo of ketamine, and 1 milligram per kilo of rocuronium. It provides optimal intubating conditions while actively mitigating the risk of post-induction cardiovascular collapse.
Medications are drawn. We finish the checklist with UP2, equipment check, and for this acidotic patient, you instruct the respiratory nurse to match the patient's massive compensatory minute ventilation on the ventilator settings.
Very important.
Then the understanding check, You pause the entire room. You state, I am the airway operator. The registrar is pushing meds. Is everyone clear on their role? Is anyone unsure of the plan?
This is the pinnacle of crisis resource management. You are flattening the hierarchy. If the FY2 notices the blood pressure trending down, they need to feel empowered to speak up immediately. Once that closed-loop communication is confirmed, you give the order to push the drugs.
The moment of induction arrives, the drugs are in. You watch the monitor. The patient's jaw relaxes. You manage your own internal stress response. That's the pedal up emotional domain.
Keep your heart rate down.
You take a slow, deep box breath. You take the universal video laryngoscope in your left hand, using a light 2-finger grip to avoid levering on the teeth, and you initiate the EVLI sequence.
First, epiglottiscopy. You introduce the blade, locate the uvula, and follow the midline down until the epiglottis comes into view. Next, folliculoscopy. Seat the very tip of the blade precisely into the follicula to engage the hyoepiglottic ligament.
And then?
Third, laryngoscopy. You apply a firm, forward, and upward lifting force, aiming the handle toward the opposite corner of the ceiling. You never pull back toward yourself.
You have your view. Now, intubation. You ask your airway assistant for the tube, and ideally it's preloaded with a bougie. I want to touch on the driver trials here, because using a bougie for every intubation, even the easy ones, is a strongly advocated practice now.
The driver trials demonstrated significant improvements in first-pass success when a bougie is used routinely in the ED. But beyond the immediate stats, it's about tactile mastery.
Building that muscle memory.
Exactly. You build muscle memory by using the bougie on grade 1 views, so when you are faced with a grade 3 view and the airway is flooded with secretions, your hands already know exactly how to manipulate the device.
Let's simulate that complication. You try to pass the tube over the bougie, but it catches. It's hung up on the right arytenoid cartilage. It won't advance past the cords. The monitor's pulse ox tone starts to drop slightly in pitch. Beep, beep, boop.
This is where mental reversal saves the patient. If the tube catches on the arytenoids, the very first subtle troubleshooting move is to rotate the endotracheal tube 90 degrees counterclockwise.
Just a simple twist.
This simple twist turns the bevel of the tube away from the cartilage, allowing it to slip smoothly through the vocal cords.
But what if you're still struggling with the view itself? Like the screen is just a wall of pink tissue. This is where we initiate the Kovac-Kata maneuver.
I see this exact scenario frequently with junior registrars. They get severe tunnel vision on the video screen, they bury the blade too deep, and suddenly the monitor is just a wall of white or pink tissue.
And pulling back feels entirely counterintuitive when you're desperate for a view.
It does, but it's often the only solution. So you run the Kata. Neck ensure the patient hasn't slipped out of flextension. Head use your right hand to extend the head slightly further back at the atlanto-occipital joint. Hands utilized by manual laryngoscopy, manipulating the larynx externally to optimize the view on the screen, then have your assistant hold that exact pressure.
And if the epiglottis is still obscuring the view?
That brings us to scoop. If the epiglottis is floppy, you transition the Mac blade to act almost like a straight Miller blade, physically scooping the epiglottis up directly.
And the final step.
Finally, the move we just mentioned, pull back. If you see Kovac's sign, which is the white ring of the glottic inlet taking up the entire video screen, you are too close. You have zero room to angle the tube. You must physically pull the blade back a few centimeters to broaden the panoramic view and create the functional space needed to pass the tube.
You pull back slightly. The view opens up beautifully. You pass the bougie, railroad the tube over it with that 90-degree twist, inflate the cuff, and confirm end-tidal CO2. You've got the tube.
Excellent.
But, as senior clinicians know, securing the plastic is only halfway. The post-intubation phase is incredibly dangerous.
It's arguably the most vulnerable time for the patient. Suppose 5 minutes later, the oxygen saturations begin to fall. You must instantly recall the Doppler's mnemonic to systematically troubleshoot the hypoxia.
Displacement of the tube, obstruction of the tube, pneumothorax, equipment failure from the vent, or stacked breaths causing auto-PEEP. And what about hemodynamics? The monitor suddenly shows a MRAP dropping into the 50s. A lot of practitioners might reflexively grab a bag of plasmolite or saline and squeeze it in under pressure to treat the hypotension. Why is that the wrong move here?
That is a very dangerous trap. Recent critical care literature, again heavily supported by the driver trials and subsequent critical care data, shows that dumping liters of crystalloid fluid into a critically unwell, shocked patient undergoing RSI has very little evidence of success.
It doesn't fix the underlying issue.
No, it doesn't fix the vasoplegia caused by the induction agents or the systemic inflammation. In fact, it often causes harm by contributing to fluid overload, ARDS, and worsening right heart failure.
So what's the move?
You need to immediately initiate and titrate vasopressors, like a norepinephrine infusion, to actively clamp down the vasculature and maintain a MEP over 65 millimeters of mercury. You must actively manage the physiological crash you prepared for.
Let's step out of the rhesus bay for a moment and transition into part 3, the reflection. The tube is secure, the pressors are running, and the FY2 is catching their breath. Let's debrief this scenario from an external perspective, focusing heavily on human factors and team leadership.
As a consultant, when you watch yourself from above, you need to ask, was the shared mental model actually effective?
Yeah, during that understanding check.
Did the team just nod silently? Or did they actively engage with the clinical trajectory? Did you delegate tasks like the ultrasound IV and the salad setup clearly enough that you could maintain broad situational awareness?
It's a great point. Let's synthesize the key learnings from this simulation against our high-level metrics. First, looking at decision-making and timing.
The hallmark of senior practice here was the discipline to not rush, recognizing the hop killer's hypotension, oxygenation, and pH, and proactively choosing to resuscitate before intubating using a ketamine DSI. That is advanced timing management.
Second, technical skill and physicality.
This was about perfecting the biomechanics, executing precise flex tension to align the airway axis, and methodically walking through the EVLI sequence, utilizing the bougie to ensure tactile dominance over the anatomy.
Let's talk about physiological resilience. This is perhaps the most crucial element we navigated today.
Absolutely. The team successfully managed the CRH threats during induction. You matched the ventilator to their severe compensatory acidosis, and crucially, you tailored your pharmacology.
The 1.1.1 regimen.
Right. By explicitly choosing the 1.1.1 Lions regimen over the 3.2.1, you protected their fragile hemodynamics from the vasoplegic effects of standard dosing.
What about predictive tool application?
You demonstrated high-level clinical reasoning by discarding the anatomically focused Lemon tool. For this specific patient presentation, the Heaven criteria were essential, correctly identifying that the systemic exsanguination and hypoxemia were the true immediate barriers to survival.
We also covered troubleshooting review.
When the tube caught, there was no panic. The 90-degree twist was seamless, and the deliberate deployment of the COAF CATA, specifically recognizing Kovacs sign and overcoming the instinct to push deeper by pulling back to create space, was textbook problem solving.
Which all culminates in our definitive success metric. You didn't just get the tube, you achieved the gold standard DHH-1A, you secured a definitive airway without precipitating fatal hypoxia, hypotension, or hypercarbia on your first attempt.
And through it all, you seamlessly integrated the 2025 Difficult Airway Society guidelines. You utilized continuous apneic oxygenation through the 1515 setup, you standardized your positioning, and you employed universal video laryngoscopy as your first-line approach to engineer the best possible view.
It's an incredibly intense cognitive load. Modern emergency airway management is a beautifully complex orchestration of physiology, pharmacology, and team dynamics. As an EM consultant, your ability to visualize, anticipate, and execute this level of care is exactly what prevents peri-intubation arrests at 3 a.m.
I do want to leave you with one final thought to mull over, specifically regarding the trajectory of those 2025 DAS guidelines.
Go ahead.
The guidelines represent a massive, intentional shift toward engineering success through technology. We are now relying on universal video laryngoscopy for every intubation to guarantee a shared screen view, and we have standardized the vertical incision for surgical airways.
It's a huge leap forward.
The technology is undeniably incredible for patient safety, but it raises a critical question for us as educators and operators. As video laryngoscopy becomes the universal standard, how do we ensure that our trainees, and we ourselves, do not lose the foundational tactile mastery required to save a life when the screen inevitably goes dark, or the camera is blinded by blood, and you are left with nothing but a direct blade and the physical feedback in your hands?
It's a brilliant point to ponder as we balance technological advancement with core clinical skills. Take this mental model, the IOD, SOAP, ME, UP2 checklist, and that critical reflection into your next shift in the rhesus bay. Keep pushing the boundaries of your clinical mastery and keep visualizing the physiology behind the anatomy. Thank you for joining us on this deep dive.